Yes, thank you. For those of you who are not on the island, I think that gave you a first impression, not only of this year's summer school, but of all these annual summer schools, which we as the European Observatory on Health Systems and Policies have the pleasure of hosting here in the Veneto region. My name is Reinhard Busse. I'm the director of the annual Observatory Summer School. But before we open and go into the contents of today's session, I'm very pleased that we have three persons here representing very important co-hosts for us as Observatory in this event, the Veneto region, the World Health Organization Regional Office for Europe, and the European Commission. And Luciano Flor from the Veneto region's Directorate for Health and Social Affairs will make a start. Please.
Grazie, grazie professore. Io saluto volentieri.
Thank you very much. I would like to welcome you on behalf of the Veneto region. I really welcome you also on my personal behalf. I would like to thank the director of the summer school and of the observatory, Mr. Busse, but also Mr. Figueras, for their contribution and their inspiration to our activity. I must say that it's nice to meet in person after 2 years of remote conferences. We were able to organize events during the 2 years of pandemic, but hopefully, really hopefully, fingers crossed, we are starting a new era in terms of open in-presence meeting. This is the 17th edition of our summer school. This is something that is very dear to the Veneto region, the managers of the Veneto region, and the government of the Veneto region, because we've always been very interested in what is happening in other European countries, but also the scientific developments that can be brought about, for example, by the WHO, or we are interested in the contribution by the Commission. Now, being here means look into the future. We are ready. We want to look to the future, and we want our region to have a quality, a homogeneous quality standard, not just high quality standard, because the high quality standards must be homogeneous everywhere in the region. We don't want to have just peaks of excellence. And this is why I would like to cooperate with national and international players. We want to be listeners and to also provide some advice if this is possible. Thank you very much.
Yeah, grazie. And thank you again for hosting us, not only for the summer school in general on the island, which we just saw, but also especially today in this beautiful Palazzo Franchetti. Without further ado, I think we move one on. Natasha Azzopardi Muscat from the European Regional Office for WHO European Regional Office for Europe, representing the unit for health systems and for health system support, and with whom we work greatly and closely together as a European Observatory, and WHO is also very supportive in hosting the summer school.
Thank you very much, Reinhard. Buon pomeriggio, good afternoon. It's my pleasure to be here and to again take the opportunity to officially welcome you all to this Observatory Summer School. As the WHO Regional Office for Europe, it is always a pleasure for us to work with our partners, the Observatory, and also with the European Commission. Why? Because the European Programme of Work is really having at its heart the importance of partnership in order to implement effectively and successfully. For me, it is a double pleasure to be here in the Veneto region, where we also have our Venice office kindly hosted by the Veneto region, working very much on health and development. I think the theme of this year's summer school, innovation, the COVID pandemic, some of the challenges that are really placing policymakers with huge pressures across the European region at the moment as we seek to recover from the COVID pandemic, in the midst also of the conflict that is taking place in our region, and where we find that our health services after 2 years of pandemic are overstretched and overburdened. We need to be creative and innovative to rise to this challenge, because it is in adversity that our best comes out. And in order to do this, really, we must listen to everyone. And I think that in the kind of summer school that you create here on the island of San Servolo, the rich debates, it's not only about teaching, it's about learning, implementing, and innovating together. And of course, for us as WHO, this is at the heart of what we do, building capacity within countries to bring about better health for all. Thank you.
Thank you, Natasha. Now it's my pleasure to introduce to you Isabel Della Mata. Isabel Della Mata is Senior Advisor at the European Commission's Directorate-General for Health, DG Santé, for public health measures, also representing the Commission on the steering committee of the European Observatory, and very instrumental in supporting us in setting up the summer school. Isabel.
Thank you very much, Reinhard. Good afternoon to everybody. It's a pleasure for me and for the European Commission to be here today and to be co-organizers of the summer school of the Observatory. We decided already some years ago that apart from being partners of the Observatory, we will move to be also co-organizers of the summer school, because it's a very good tool, an innovation tool also, to discuss with the persons that are working in the health systems in Europe, in the European Union, but also in Europe and also for the of our borders, the topics that are important for the development of our health systems and policies. So we thought that was a step that was a logical step in our involvement of on the observatory, and that the summer school that have developed for many years, and really was a pity the cut that we have had in the last 2 years, but due to the pandemic, and I'm very happy that we are back again in presence, even if I have seen that we have around 100 participants online. That is also very important. And one of the parts of the summer school has always been this session in the Palazzo Franchetti, and where we involve other people, not only the ones that are in San Servolo without escape the whole week enclosed there discussing, but other people, especially working in the region of Veneto, and that for different reasons you are not participating in the whole summer school, but that you have the opportunity to be present today, to discuss with us, also to meet the other colleagues that are the whole week. And maybe that will give you the flavor and the wish to come next year and to participate fully in the school. So the topic of this year is very important, but has been, I mean, the topics of every year are very important for the health system and also for the Commission. Innovation in the last year due to the COVID, but also in general, I mean, we have been moving to use more and more technology, but doing things also in a different way, and the role of the health professionals has been changing over the years. So we will discuss later on the experiences at the regional level in Veneto, but also what the different participants of the second roundtable we could bring as a experience. So welcome to this roundtable of the Palazzo Franchetti, and welcome to this flavor of the summer school. Thank you.
Yes. Thank you a lot, Isabel. Colleagues, you can stay there or you can move back to the auditorium. Maybe you can then see better. These are relatively small screens here. What we will do now, I will try, which is obviously impossible, to squeeze a 1-week summer school into 12 minutes to at least give a flavor and a contextualization for those participants joining us online. And this will be followed by 3 examples from the Veneto region. Implementing innovation. How do we make best practice work? And I will explain in a few minutes really that there are 2 very important concepts already in the title, or even 3: implementation, innovation, and best practice. And next slide, please. I mean, often innovation, and this was not always the case when we go historically, innovation did not have this positive connotation as we now sometimes overstated do it. Like when you see this, and often when you Google and look for innovation, it tells you that innovation is good per se. Innovation saves lives. So we would be stupid not to adopt any innovation coming along. But surely this is an oversimplification, and the school is about to help us, to help the participants, but also us from the observatory, those of us who organize that, to disentangle what is really meant. How can we stimulate innovations which work? How can we help them to be implemented? And how can we sort out those which are not real innovations? Next slide, please. So when we designed the school, we were careful to then phrase questions, not only for you as participants when you sign up to understand what this will be about, but also for the faculty clearly and for the policymakers, and say these are the important topics to consider. So to understand innovation and change in health systems and draw on the field of implementation science, to explore the different challenges of implementation relating to different types of innovations, including biomedical, technological, and organizational innovations. To delve into the roles of different stakeholders in implementation, including patients, professionals, payers, and how policymakers can best support these processes. To learn from good practice elsewhere and the potential for collaboration between European health systems. To master techniques for bringing about constructive change and discover models for supporting effective change processes, including processes of de-implementation. Very important. Innovation is not always doing something new, but also leaving away, getting away from things which are no longer working, or where we now have better technology. And last but not least, to understand how European tools can help to support change in health systems. Important is also to learn vocabulary. And there is a vocabulary that we need to disentangle the various stages in innovations as they become innovations. So we have started the school that at the very beginning to say, okay, we need to look at the different words. Usually something new ideas start with a discovery, the first initial addressing in a gap of knowledge through generating new knowledge, the first insights of an aspect of a disease, for example, which opens up possible new ways to treating it. Then an invention is following. Once this novel insight becomes taken further into something potentially feasible application, this can be termed an invention. So the discovery plus the feasibility, one of the questions we need to look at, how can we promote inventions? And then we move into the red marked areas, the core of this summer school, innovation, an innovation which is capable of being used, but how do we ensure that it is addressing any need? How do we know that it is really effective in doing so? So innovation can be described as invention plus potential application in practice. And only then we talk about implementation. So if we have a promising innovation, we only, in inverted commas, have to implement it, so that we need to ensure engagement for and the actual use of innovations in practice. And if we do that, if we not only find out about it, it can stimulate successful innovations, but also how to implement them successfully, then we can scale them up and make our healthcare systems more effective, cost-effective, responsive, and so on. Next slide, please. I already said we talk about different types of innovations. We have biomedical innovations. Typically, many people in medicine first think of them focused on the better understanding of an intervention in the biological systems and affecting the body. Pharmaceuticals are a very good example of this one. The research is rooted in life sciences principle that this has universal application. Then we have a second group, not always clearly distinct from it, with some mixtures, overlaps, what we call technological innovation, focused on the use of technology. There's a caveat, as you see there, that people who do health technology assessment coin all technologies, and not only those technologies which some people call the technical technologies. The research on them is rooted in the physical and information sciences, and again, in principle, have universal application. It's a wide range from medical devices such as artificial hips or monitoring devices through to platforms for telemedicine or machine learning algorithms. And we also hear something from the Veneto region in this regard. Then we have organizational innovation, focused on how organizations and systems work. Its research is rooted in the social sciences, and its results relate to different contexts of each health system and each organization within it. Next, please. But then we also have multi-layer innovations. So we have a medical device, for example, and which we want to implement it. And we also have a technology, for example, pay for performance, which should stimulate it. But we combine different innovations. We have the technological innovation and the organizational innovation to go hand in hand, and we need to keep this in mind. Next slide, please. We started then, and then we went deeper and say, okay, when we want to know when an invention is really an innovation, we need to take care of what does it mean. So what makes something which makes an invention an innovation? Where are the benefits for patients, the benefits for the system? And there's a wide range of dimensions to consider. The most important ones are listed here, and they go into health, but they also go into other dimensions. Next slide, please. Then, once we know that we have an innovation which should be used more broadly. And the big thing is, yeah, but now what? How is it picked up? And from my colleague here, Michel Wensing, yesterday in his presentation, I took this one, and he cited his previous boss in the Netherlands, Richard Grohl. And Richard Grohl says, well, it's also a part of perspective. And this is the interesting thing also about the summer school. People come from very different backgrounds. And when you come from very different backgrounds, you have a very different perspective on what implementation means. If you're more a scientist and epidemiologist, you think you publish it, people will read it and do the best what they can with the information. Other thing, you give feedback. And if you give feedback, then this is enough. An information specialist would say, we adopt decision support systems, and then automatically people will do what the decision adoption system will tell them. Others, economists will say, well, we pay for good practice. So if you pay them more, people will automatically implement it. And so we have very, very different ideas here. Next slide, next, please. But in reality, implementation is usually a mix of these things. All these are not wrong by themselves, but they are incomplete. And implementation is a mix among these things and others. For example, you don't find putting a law, for example. So I could give more examples here of implementation to follow. Next, please. And then, and often this is not so clear, and we disentangled this morning. We said, okay, but we need to, often we have studies where we are unclear, do the studies actually study the effectiveness and the cost effectiveness of the technologies, or do the studies actually look at the implementation? And systematically, we need to disentangle. We need to first look at the potential effects. So this is the health technology assessment view. Is this technology able to be effective, safe, responsive to patients' needs, and so on? And either it is or it's not. But then we can also look at the implementation strategy. Did we choose the right implementation strategy? And the good thing is, when you think now about COVID times and vaccination, the one thing is you look only at the vaccine. Is it effective in dealing with the disease? And the implementation strategy would be an immunization campaign. And already see it's not exactly the same. Not that you offer immunizations, everybody is taking it, that there will be different implementation strategies to actually roll out a vaccination program. And then it's easy. If both the technology is working and the implementation is good, well, then we should scale it up. It's something which works. If the innovation itself is not an innovation, so the invention does not work, does not carry the potential, and the implementation strategy is bad, okay, forget it. We should not adopt it. And then we have two other fields. Next push, please. They might be ethically, but they exist. They exist. We have areas where we have an effective technology, but the implementation doesn't work. And there can be a variety of reasons. I don't want to go into them. And vice versa, even maybe more paradoxically, we have a technology which is not really effective, but which is still implemented very, very successfully. And so we have to disentangle that. And we hope that during this school, we can move more systematically in this direction to help us to all become better in tackling this. Next, please. This one, okay. Then we will go on. As I said, the summer school is a week long. We then look at the environment. So how can we promote a constant environment? This idea thing is derived from times where you think clever people sit somewhere in their office and come up with bright ideas. In reality, we need an environment which is really helping all of us, the people on the ground, in the healthcare services, the people administering it, to really see it, to see it as a cycle, making sense, be critical what is happening, where are the gaps in our knowledge, where do we collect the data from, both for current practice and new practice. And next, please. And especially when it comes to data, and we had in the objectives also to look at instruments where European institutions, WHO, the Commission can help countries and regions, and we will look. This is an example here at the European health data space, and how this will help us hopefully in the future to better get feedback on where we are when we implement innovations. So some is for those of you who are participants in the school is already looking back. Something is still looking ahead. And those of you who follow us online and other people joining us here in this beautiful Palazzo Franchetti, at least I hope you got a very brief flavor of what we are doing here in this week. Okay, I'm done here. Without further ado, we now look at 3 case examples from the Veneto region. And we start with Michele Tonon, who gives us the first presentation. Please come here.
Buon pomeriggio a tutti.
Good afternoon, everybody. I will try and cover a topic which is quite up to date. I would like to walk you through the fact that surveillance of infectious diseases may draw benefit from the experience of the COVID-19 pandemic. We will see how we can actually bring into the surveillance of infectious diseases some elements that were introduced by the pandemic. We can say that basically what is important in relation to infectious diseases is surveillance. This is at the basis of data integration, data collection and integration, and epidemiology surveillance to identify possible issues, possible threats, and monitor the risks. This goes hand in hand with the decision-making aspect. Epidemiology data, indeed, should lead to planning interventions in order to contain and limit the risks and the threats that have been identified. Of course, all of this has to be monitored because the impact of all these actions and interventions is felt in terms of community public health. Traditionally, before COVID-19, in our society, surveillance for infectious diseases was limited, rather limited. Usually it was an operator-dependent surveillance, a case-by-case surveillance, and there was no structural integration with other healthcare databases. What was done in the Veneto region, thanks to a regional organization that has involved Azienda Zero, was to develop a centralized surveillance system, a system that integrates data collected by the different hospitals in order to ensure timely monitoring, integrated monitoring, and uniform monitoring throughout the region. We have integrated information. We have developed a real-time surveillance system. We've also developed systems to simplify the work and activities of individual operators by streamlining their workload. But above all, there was a need to return the information on individual patients to the various actors of the healthcare system. The main elements identified during the COVID-19 pandemic in relation to surveillance of infectious diseases were going from small to big numbers, implementing systems of reporting, supporting operators, integrating data from different sources and sharing information, speeding up collaboration among the professionals that are involved. In order to be able to put all this into a single system, we need to combine all the information to ensure surveillance of infectious diseases. All these elements imply that the innovation elements are used for other infectious diseases as well. There are several steps to go through. We are, for example, mapping the information currently available in the databases so that we can identify infectious disease alerts. I'm not referring to COVID-19 now, but I'm referring to all other infectious diseases. Integrating information may help us develop alert systems that can be validated by the prevention departments in a guided surveillance process. Therefore, reaching the conclusion of this talk, I will focus on the difficulties and challenges that implementing a new surveillance pathway for infectious diseases implies. Surveillance of infectious diseases remains complex. We know that information comes from different contexts, different settings, without forgetting the One Health concept as well. I think that we have to make an effort, both human medicine and veterinary medicine experts. And then, of course, doing this after the pandemic means that we all suffer from pandemic fatigue. Another issue is data protection regulations and the need to work by integrating and standardizing the work and activities of people working in different hospitals, in different local health units. Introducing a single regional centralized system means that standardization is supported, trying to find a shared and common way of working. What are the elements that can be useful to overcome all these challenges? Using tools which, in a way, simplify our work. Actually, a tool which is perceived as a way to streamline surveillance may be easily accepted by the operators. Another element is quick return of information to the healthcare workers, and also the development of user-friendly systems, which is, in our opinion, a basic element. User-friendly systems can be used by all healthcare professionals in spite of their knowledge of technology. Therefore, in a process of development of all these apps and programs, the healthcare professionals should be involved. This is the pathway we're currently going through. It can certainly be accelerated given the experience gained following the COVID-19 pandemic.
Yes, thank you. I mean, we all know that was a big challenge everywhere, in every single region, every single country, how to manage that. Do we have a direct question to our presenter? Yes, please.
Thank you for the presentation. I just wanted to ask, how automatic is it? Because we are collecting a lot of data in Carinthia, and it means that a lot of the controlling people are occupied just with providing data for some central database where we, in Austria, we don't really get much data back as a hospital.
Allora, l'automatismo, l'automatizzazione è ovviamente
Concerning the automatic approach and system, we are currently approaching this. We're currently addressing this. Are you asking because of COVID-19 or other infectious diseases?
Allora, per quanto riguarda il
I'm
Covid,
referring to COVID-19. So for COVID-19, the system is automated. We collect data directly from the labs, from the hospitals, from the GPs, from the pharmacies, and all this information is integrated with the information that can that relates to, for example, how tests were performed and all the information, that is entered by the hospitals or GPs. We're working at also upgrading the infectious disease software, including gradually all other infectious diseases, not just COVID-19.
Thank you. In relation to COVID-19 vaccination, were you able to perhaps expand the epidemiological surveillance system to special populations, vulnerable populations, particularly populations on the move, like migrant populations?
this was more difficult, of course, because it's difficult to track migrants population or population with those kind of social vulnerability or frail social population. This was a little bit more difficult. And so we had to work with other stakeholders in order to grant specific or more focused activities or actions in order to promote vaccination in those kinds of populations. It was difficult to do it on some kind of automated or other kind of systems with tracking this kind of fragility. Yes.
Michele, thank you for these interesting examples. Yes. Well, then we need to go first there. No, there's no jumping the queue, then we... No, even you don't have it?
Hi, I wanted to know if the notification requirement for infectious disease, is it mandated by law?
Yes, yes, it is.
Okay.
That's not.
Short question, who was behind this? It's very difficult to get the right IT people to move fast and to work with the health professionals. This is a big challenge. How you did it, it's really impressive in such a short time.
I think that to face the first stage of pandemic, everybody worked really hard to innovate and to find new ideas and new opportunities. So it was a team group. Everybody did his part. Azienda Zero, who is did a great, obviously a really important job, but also the local health unit, healthcare workers. For example, the software we are using now to monitor and track and or the contact tracing or other activities of public health activities for COVID is used by all our health workers in the health department. And they helped us to design and to decide how to build the software. So this process was a team process, of course.
Mirko, many thanks. He's here during the coffee break. Ask any other questions to him directly. Maybe that was Michele. Yes, Mirko, Claus is next on with the second presentation.
Questa diciamo è la
This
rappresentazione.
is the graphic representation of how COVID accelerated the most important aspect, which is a regulatory aspect. Well, of course, when COVID started, we only had general regulations dating to 2014. Then COVID-19 occurred, and then starting from 2020, we had legislation, national and regulation and regional regulations for remote healthcare services. In blue, you have national guidelines, as you can see, for the reasons, and in red or yellow, you can see other types of regulations specific for telemedicine. In particular, €1 billion was allocated. And then in 2022, we had the two pillars. We had two guidelines in stating how these digital home care and telemedicine can be provided. In particular, we had digital models for home care, and this was April 2022. And then we have models and standards for the development of primary health care at a community level. And this was adopted by the central government just a few weeks ago. And it's important to say that the pandemic has taught us how we need a political will to overcome some barriers. And also, of course, economic incentives are required. The Veneto region has immediately adopted the national legislation on telemedicine. And so the same payment was provided for telemedicine as for in-presence medicine. And the different types of telemedicine services, of telemedicine operations were defined thanks to the first national and then the regional regulation. We have a telemedicine examination, for example, and it was defined that the current remuneration are the same as in-presence examinations. So there was a perfect equivalence between an in-presence service and a telemedicine service. This is a graphic representation of the impact of implementing this national legislation into regional context, into the regional context. You can see that in 2021, we had a lot of telemedicine services, of course. But in particular, we had follow-up visits for especially cancer patients, diabetic patients, for whom telemedicine was possible. Actually, this proved to be very safe for these frail patients who were better cared for in a telemedicine mode. Now, the Veneto region started with its experience with telemedicine 15 years ago, so it's not something new for COVID-19. Different players took part in national and international experimentations on telediagnosis, teleexaminations, telerehabilitation. So different projects which lay the basis, the foundations of possible future developments, and which paved the way to a more fruitful use of telemedicine during COVID. In particular, for COVID-19, primary health care was provided also with in a telemedicine mode, and for some specific diseases, for example, multiple sclerosis. So we had a specific project for telemedicine services for multiple sclerosis patients. And also there was a project for health literacy that was an experimentation in the Verona area. These were all, let's say, single individual experimentations, very local. Now we are having whole of the region experimentations, which are making innovation, the implementation of technological innovation more easy. The Veneto region has more than 5 million inhabitants, 68 hospitals, and there are 9 local health authorities, 2 university hospital trusts, and there is 1 cancer center, which is the Veneto Oncology Institute. And of course, telemedicine had to base its pillars, as it were, on these on this basis, but it also required a region-wide, let's say, a region-wide basis, and this was the so-called Azienda Zero, which was providing IT infrastructures, connectivity, information systems, and data flows with a view to homogenizing the ICT systems, because the idea is convergence, converging. This is the most important point, with patients at the very center. How did we provide telemedicine? Well, by the, first of all, the establishment of a working group, people who were responsible for mapping needs and mapping existing services, and then drawing up service standards. And in particular, Azienda Zero here was instrumental for providing technological information in computer-based support for this drawing up. Then we had an expert group who reviewed and made comments, and also these groups were able to come out with televisit or teleexamination, teleconsultation, telemonitoring, telereporting, telerehabilitation, so that we could have a system-wide type of telemedicine. We are now in a very important transition moment, because we are moving from local experiments to whole region system, with a system covering the whole of the Veneto region, because we have now a national, an Italian platform, but we have 20 regions in Italy, and of course, all the 20 regions must be able to make the best possible use of the national telemedicine platform for televisit, teleassistance, teleconsultation, and telemonitoring. So, as I was saying, we had cutting-edge local experiences to now a region-wide system based on a national system. We have an integrated system with electronic patients' files that provide information and documentation, of course. Another ambitious project in the Veneto region is to have a single hospital information system, so that information is shared by all hospitals of the regions. And we also want to have a home care digital model. This is, of course, parallel to the hospital. This is another important element, the home care digital model, which is part of the National Plan for Recovery and Resilience. Now, telemedicine is not more a separate system. It's part of the whole system. It is just one of the ways in which medicine services are provided. But of course, this is something that patients require. This is something that in some cases it is absolutely needed. And for this reason, we needed to have experts. We needed to have, of course, these working groups, these expert groups that could help us. But of course, a legal framework is important. This is probably a fundamental prerequisite. And also the engagement of people is absolutely essential. We need to align objectives between the different healthcare trusts and to harmonize them. And we need to be aware that telemedicine is introducing new forms of providing healthcare. At present, these new forms are not sufficiently regulated, are not, as it were, coded. And through telemedicine, we could have a better harmonization. So telemedicine could be an instrumental tool to have a better and a more harmonized system for the whole of the patients in our region. Thank you very much.
Mirko, thank you. This is again a perfect example of something where we could discuss where we are on the innovation implementation chain. Clearly, we were helped. Some of us might overestimate the numbers. You said it's 1% of total consultations. In Germany, it's about 0.2% of all consultations. And clearly we are seeing these new developments. Any quick questions? We can take one or two, and then we need to move on to the third presentation.
Thanks very much for both the presentations so far. It was the same question for the earlier presenter as well, actually. I'd love to hear your perspective on how you go around with who actually owns the data. So where I come from, we have the concept of data controller, data processor, data accessor, and depending on what the arrangement is, you might need to legislate or regulate or collaborate. So I'd just like to hear your perspective on that.
Yeah.
Would you like to take the other? Yes, we take the other question.
So, is it possible for a doctor that he uses this telemedicine system to prescribe it to a patient? And if yes, have you seen any decrease or increase to your pharmaceutical expenses?
Regarding the contracts, if it is a private system contracted or developed by inside the Italian government, and if it is in a private partner, what were the details to protect the data if it is kept outside the state? Thank you.
Yeah, data ownership.
Thank you. I would like to know your concept on teleconsultation, if it includes like a phone call from the doctor to the patient or an email, an exchange of emails between doctors and patients. Is that included in the concept?
Yeah.
Thank you.
Okay, I'll go through quickly. The first question is about data ownership. So we have the fortune to be part of a mostly public system. So our local health authorities are the owner of the data, and there is a consent from the participant, so the patient in this case, to allow them to treat the data. But we've gone through a very thorough process with our GDPR and DPO experts to grant this access, because the platform will be regional at that point. So, but the data will be kept at the local level, where the procedure, the visit, will be actually managed and then done. About the prescription, so we have the idea. Actually, this number of procedures has been done through small experimentation in local setting, in local health authority setting. So we don't have still the regional platform, but we already incorporated the prescription module. So since 2005 in Italy, we have the electronic prescription system. So everything is going directly to the Ministry of Economics and Finance, and then come back to the provider. And so everything is going everything electronically by now. We don't have the chance by now to match the use of telemedicine, visit, consultation, and the number of prescriptions. So it will be interesting to look at the data then. I will go to the private partners. So the DGR of the 2020, so the first wave that allowed procedures to be done via telemedicine, was also for private accredited hospitals. So they use the same financing scheme, and they were reimbursed in the same way they are for normal in-presence consultation. So there is no special agreements, and yeah, I think depending on the number and on the amount of the procedures and visit done via telemedicine, we will need to adopt another scheme, because maybe some private partners will shift towards this kind of offer. But right now, the scheme and the contracts are the same. What about the telecom consultation is mainly referring to the synchronous and asynchronous teleconsultation. So we have two medical professionals most that ask a question and would like to have a signed certification about something on a common patient. So this is, I think, the most innovative thing, because we are going to track and to record who is asking what and to which detail. And like in a hospital, when some specialist is coming to another department, now we have track of what can be supported for the patient's sake, so to say. And yeah, it's going to be, in my opinion, the leverage we can use for building the network to have kind of a real network made upon consultations, and way of connecting professionals that are not sharing the same hospital, the same room, or the same department, but they can meet once in a year.
Thank you.
Yeah.
Thank you for the second interesting presentation. Now we move to the third one. It's Alberto Bortolami. Please come to the front.
Sì, buon pomeriggio, grazie dell'invito, è un privilegio essere qui.
Good afternoon. Thank you for the invitation. It's a real pleasure to be here. I will not talk about COVID-19. What about the best practices of our region concerning pharmaceutical governance? First of all, access, choice of drugs, and governance of resources. We've always paid great attention to this. And then another aspect, which is about an innovation process. At the present time, we have a lot of interest in precision oncology and agnostic drugs. This has led to a change in the regional organization, and I will talk about the Molecular Tumor Board. Let's talk about pharmaceutical governance first, what we do in the Veneto region. Governance takes place through access, choice, and resources, and multidisciplinary groups at regional level. all these selections, all these choices are made in a multidisciplinary way. The EMA defines the efficacy, safety, and quality of a drug. AIFA, the Italian Medicines Agency, defines pricing and reimbursement. Regions in Italy have to plan healthcare services and allocate financial resources. The region has tools available to make these activities very specific. The region has always had guidelines to define the criteria for prescribing drugs. Then the region defines which centers are authorized to prescribe certain drugs. In the Veneto region, not all centers can prescribe all drugs. This is the result of a specific choice because, you know, in some drugs, you need high expertise for prescribing them. I'm referring to rare diseases, oncology. So the choice was to restrict the prescription to certain centers only. Then health technology assessment is another governance tool in our region. There is a tendency towards using biosimilars in the hospitals to ensure the best type of care at lower costs. We monitor and report of medicines utilization and expenditure. And then we define spending caps. Year on year, we try and understand what the spending is going to be, not only for drugs, but also for IVD and medical devices in general, both in hospital and at community level. There are multidisciplinary working groups which ensure this governance. The Regional Technical Committee for Medicines identifies the centers that are authorized to prescribe certain drugs and allows us to monitor drugs all the time at regional level to see whether they're overused or underused. All this is supported by Azienda Zero, which was mentioned before by another speaker, concerning high therapeutic impact drugs, orphan drugs, and high economic and or organizational impact. The region decides the drugs to be assessed following these three criteria. As for the resources, we define spending caps. Year on year, we predict what the economic impact is going to be. We use indicators. We try and understand which is the case load. We try and analyze the spending trend record. We analyze the Italian Medicines Agency registers. We analyze the innovative drugs. We do a budget impact analysis of new drugs and also identify savings factors. In 2021, we had approximately 2.129 billion euro as a budget, and now we have increased this value by 111.7 million to ensure the best care to our patients. Then the chief medical officers and the managers have targets to follow at a territorial level. So every manager will have targets to reach in order to comply with the guidelines of the region. The Veneto region is the first one that has set up a molecular tumor board. In just one slide, I will show you what the modern oncology is and how it is evolving. We've got used to studying drugs for one single disease like lung cancer. In the future, we will consider molecular mutations and many more diseases. From a biological, we'll go to a molecular approach. For example, some drugs that have indications for lung cancer can be used for other diseases as well. This will create a sort of chaos initially. This worries a little bit, but what is important is to understand what the process is like, to see which patients can have access to certain diagnostic procedures. We need to ensure quality of care for a new model of governance. We know that we have 30,000 new cases of cancer a year in our region, so it's a true pandemic. We have to consider molecular mutations for all of them, etc. We have to ensure access to care, innovation, and sustainability to all patients in the region. All this has to be related to the patient because we have to pursue patient-centered care. That's why the molecular tumor boards, the MTBs, were set up to harmonize practices at regional level, first of all, to correctly interpret the results of genetic profiling. Who should do this? A multidisciplinary board, the Molecular Tumor Board, which includes the best experts in the region. Molecular pathologists, molecular biologists, a bioinformatic expert, a pharmacist, and case managers, well-prepared people that have to manage the patients from the spoke to the hub center. The timing to access to the drug has to be as short as possible because sometimes we're talking about patients with advanced stage cancer. We need to have increasingly developed telemedicine and e-health systems. We can't accept that the patient moves here and there. It's the professionals that have to discuss the case through telemedicine systems. This is also a research field, of course. The molecular tumor boards are instrumental to control the chaos that I was referring to before, because there may be chaos. There are MTBs linked to a single hospital or to referral centers. We have a molecular tumor board that covers 5 million inhabitants. This is a challenge for us. In 2021, last summer, the region defined what the molecular tumor board had to be like, defining the criteria for the tests, the genes to be profiled. There is one single molecular tumor board at regional level. So there is no single, no molecular tumor board for each hospital, but just one for the whole region. We have identified prescription access criteria and also a clinical pathway where each center knows how to behave. This is how the board is made up. You see, various professionals are involved. It's the Veneto Oncology Network that coordinates all of them. The network model is indeed essential. In the past few years, the network has worked very well throughout the area, and this is instrumental to managing and controlling all these professionals. The take-home message is a multidisciplinary approach is mandatory also for pharmaceutical governance. It's very important to use as many professionals as possible. And then it is also important to go from place in therapy to place in pathway. This is what the future will look like. Drugs must be given in the right way at the right place, not simply giving a drug to them.
Again, was very spot on. It's one of the topics current in all countries. It shows also that for the summer school, that implementation cannot simply mean as much as possible to everybody, but really a very tailored approach, both in your first part, that you take into account who, for example, can prescribe which drugs, and then even more specifically in the cancer examples. Anybody wants to ask Alberto a question? No, people I think want to have the coffee now, and these were 2, 3. Yes, is somebody online? Is a question? Okay, so we have the online participants question. Dimi, are you reading them to us?
I will be reading them. So
Nicole,
we have a first input from Marianna Mauro from the University of Catanzaro, and she's studying the use of technologies to support performance measurement and management in Italian healthcare organizations. So she's interested in knowing whether the Veneto region is implementing new technologies for performance measurement and management. Then we have another question from Tony Dedeo from Kazakhstan. And he or she was reacting to Dr. Mirko Claus, who mentioned that the Veneto is working towards a hospital health record. And the question is there also a strategy at primary care level? Or so will there be a single model? Will the different levels of electronic health records be integrated? Or is there going to be interoperability between different types of health records? And finally, we have a question from Anne Saror to all the speakers. And she's asking whether when building IT infrastructure, how can we integrate proprietary and open source platforms and tools?
Yeah. The first and the second one, I think, maybe. So, well, talking about hospital. Ok, vado più vicino, così parlo in italiano, così interprete può tradurre.
I'll speak Italian, it's better. Concerning the hospital side, as I said, we already have, we've had for 10 years, hospital IT systems, which are special for each hospital. The system I was referring to is one single regional system which generates coded data to form the electronic health record. So it's updated data. There are some trigger events like admission or discharge from hospital, for example, which are recorded. We think that this is a basic strategy. It's a winning strategy. It's information that should be returned to healthcare providers and patients so that we allow them governance of their own data. Concerning the other question, we know that the situation is different at community level. It's very heterogeneous. you know, we have home care records, and this is already a project being implemented. For GPs, the situation is very heterogeneous. You know, now we have electronic prescriptions for drugs and also for visits, specialty visits. The patient summary is an element which will become mandatory in the coming months, so that by 2026 we can have a more comprehensive system. We're working hard at this, both to integrate home care and primary health care, working with the GPs. I don't know whether I've answered all questions. Shall I answer the other one as well? Yes. Concerning the question about performance indicators to measure performance, you know, through specific flows for more than 10 years, through management control, we have made a very specific and detailed analysis for all flows in all healthcare sectors, emergency departments, admissions, discharge, and also home care. All this is managed by Azzopardi in a data warehousing system. And then reports are issued, which can be used by the strategic management and middle management of the hospitals. Well, this is also being assessed by external auditors in a system like the Sant'Anna system, where the assessment is on outcomes and not on the individual flows. It's a more robust system, which also encompasses dimensions which are typical of the healthcare system. And then another system measuring the performance of the regional healthcare systems and combining not only indicators on volumes and outcomes, but also case management pathways, assessments on the clinical pathways and adherence of patients to drug therapy, or, as Dr. Bortolami mentioned, provision of specialized services, lab services for chronically ill patients. We're evaluating the possibility to have detailed dashboards and indicators for the whole system. Thank you very much.
Very interesting opening here to our afternoon in the Palazzo Franchetti. We now have a coffee break for 20 minutes. Please be back here by 10 to 6. Thank you.
Welcome back to the session. Thank you for keeping it short and sharp. Later on, we have a good reception for those who are here. I'm sorry for those who are online, but the most important bit is what we share with you in the room and those online. So this session will be, again, of course, on innovations. We will start first with a presentation about the development of innovations, and then our panel is going to be about organizational innovations and on the implementation of innovation. So on the factors, on the drivers, on the obstacles, on the challenges, on the sustainability on implementing and sustaining innovation. I'll be introducing each one of the panelists as I ask them questions. We'll have a debate with them. And then I'll ask you to please prepare some questions, either for them individually, for some of them. I'll ask you please to try to begin to draw some of the lessons that you get out of their presentations in terms of drivers, successful drivers for implementation. always, of course, considering that context is king or context is queen, wherever, because a lot of the context is the most important factor, as we all know, when we're talking about organizational innovation. But as I said, we will start with presenting our short keynote speaker, who will then remain with us in the panel as well. Professor Tabernarakis, among other titles, he's Vice President of the European Research Council in the life sciences domain. He's the chair of the governing board of EIT, and of course, he's also a professor of molecular systems biology in the medical school of the University of Crete. And she's going to be talking about the development of innovation. Professor Tabernarakis, whenever you want, the floor is yours.
Thank you very much. I hope you can hear me. Good afternoon, good evening. It's really a pleasure for me to be here with you today. So thank you very much again. It's a pleasure and an honor to participate to the summer school. I'm going to take a few minutes of your time to present what is actually happening at the European level and what the European Commission, the European Union are doing to foster innovation that also is relevant to health issues, medical developments, and better health for European citizens. But since we are talking about health issues, of course, innovation in these areas requires extensive research, because most of the medical advancements that we see in our times are based on innovative research. And in Europe, we are actually quite good at turning money into knowledge. But we are not that good at turning this knowledge into products, services, jobs, money, especially for the healthcare sector. Now, when it comes to generating knowledge, of course, we are mostly dependent on universities and research institutions. And there, Europe really excels. We are doing this part quite well, but there is an innovation gap. We seem to be lagging behind the United States and other areas of the world, China, for example, in terms of turning this knowledge to innovative products and services that relate to healthcare. And in order to close this gap, we actually need, as I'm sure you are well aware already, to reinforce both these components of the chain value that results in innovation. And towards this goal, recently, actually last year, the European Commission initiated the new framework program, Horizon Europe. And therein, there are 3 instruments that exactly address the value chain that I showed you earlier. So first, we have the European Research Council, an instrument of Horizon Europe that funds blue skies, excellent research, curiosity-driven research. So essentially the research that is required to create innovative products and services, that is the raw material upon which innovation then grows. And of course, 2 other instruments that specifically address the innovation gap. That's the European Innovation Council and the European Institute of Innovation and Technology. These 2 instruments are part of Pillar 3 of Horizon Europe, that is titled Innovative Europe, exactly to emphasize this effort to better capitalize on the knowledge that we've already created through our universities and research institutions in Europe and create innovation for the healthcare sector. Now, just some specifics so that you have an idea of the scale. The ERC is endowed with 16 billion euro for the 7-year period of Horizon Europe. The EIC 10 billion euro, and the EIT, the European Institute of Innovation and Technology, about 3 billion euro. And these 3 instruments follow both a bottom-up approach when it comes to distributing their money, the funding. ERC, for example, is following a pure bottom-up approach. and the EIC part of the EIC is also bottom up. But there is also a top-down approach that defines priorities, and then these priorities are selectively supported. And the EIC has a top-down part, and the EIT is essentially designed to be a top-down, priority-driven, challenge-driven instrument. So I'm going to take a few more minutes to describe the EIT to you, because some of the activities of the EIT actually are very relevant to today's discussion, the innovation relevant to healthcare. So what is EIT, the European Institute of Innovation and Technology? It is essentially right now the largest innovation community of Europe. More than 2,900 partners, including companies, universities, and research centers throughout Europe. As I said, with a budget of 3 billion euro for the 7-year period. This includes the full complement of the so-called knowledge triangle. So on one hand, we have universities, essentially education. On the other hand, we have research centers, research institutions. And then we have companies, we have entrepreneurship that is actually focusing on translating the results that are obtained through research to tangible products and services, innovative products and services, especially for the healthcare sector. And actually the EIT, through its activities, is fostering all the components of the knowledge triangle. So in terms of education, the EIT funds masters and doctoral programs throughout Europe, especially with regard to medical education. There is special emphasis. And there, the aim is to create a mentality of innovation, especially in the young people, the young students that will then go on to become Europe's entrepreneurs. And of course, there is also focus in business creation and acceleration, as well as research projects that are driven by specific innovative mandates and targets. And through these activities, through the reinforcing all components of the knowledge triangle, actually the EIT has created the so-called knowledge and innovation communities that are now highly active across Europe. You see them here. Some of them address contemporary challenges, important challenges that we all know about, for example, climate, energy, etc. But as you see, one of them is actually focusing specifically on health, on how to develop innovative health services and products. And through the activities of these knowledge and innovation communities, the EIT is aiming to support European society towards creating innovation and bringing new services to the market, so that we can offer better health coverage to the citizens of Europe. And it has succeeded actually to create businesses that are now highly successful, so-called unicorns. So spin-off companies that have now exceeded the value, the market value of €1 billion. And one of them, quite interestingly, is related to health. It's actually a company that was created within the knowledge and innovation community that focuses on health, the EIT Health Kit. And this company is now producing new medications specific for musculoskeletal pain and other medications that are important for devastating human pathological conditions. So this is what is being happening and is unfolding as we speak in Europe in terms of what are the initiatives of the European Commission to support innovation. And I will finish with, I think, what should be the vision towards creating innovation. What we need in Europe is a long-term plan that focuses on quality, meritocracy, added value and diversification. This way, we can actually compete with the United States and China when it comes to innovation, and more specifically to innovation that has to do with important health challenges. Thank you very much, and I would be happy to participate in the discussion later on and address any questions that I can.
Thank you. Thank you very much indeed for the presentation, Nectarios, which really is very relevant to our discussion today. As we are now going to move to talk about organizational innovation, I will take a couple of short questions of clarification on the presentation. I know there are many, many questions because Professor Tabernakis has covered a very wide area, but I'm sure it'll open appetite for you guys to look at the various instruments at the European level. Are there a couple of questions that you have at the moment for him, for clarification? Even from my panelists as well? Not for the moment. Let me ask you a question then. Yes, sorry. Do we have another microphone to run around?
Only a point of clarification. In the knowledge triangle, is it because it was a top-down approach that you didn't have sectors like, providers, or I saw companies, researchers, and universities?
Mm-hmm. Yes, indeed. This is a top-down approach, which means that priorities are set by the political agenda in Europe. The European Commission really decides, of course, based always on the feedback of the scientific community. And these priorities are then placed, and then funding is allocated to support these specific priorities. But this is concerning not just EU countries, but also the so-called EU associated countries, because I see there is a question in the comments, in the chat. It's not just EU countries, but also EU associated countries, such as, for example, Israel, hopefully Switzerland very soon, the UK, if we reach an agreement, is going to become an associated country. So it's not just European Commission countries, it's also the associated countries that participate in these schemes.
Perfect. Thank you very much. If you don't mind to stay with us, then we'll come back with to you on the debate. Now let me introduce our panel today. I think we always say this thing, we're very lucky to have these people, but this time is really, really true. We're very lucky to have individuals here that actually are leading, making change, implementing innovation there at the cutting edge. So I'm very lucky here today to have you colleagues. We could start from the right of the member states. So I start from the left. This time I'll start from the left, perhaps, for the international organizations, multilateral organizations, whatever I want to call you, the WHO, Euro, and the European Commission. Natasha Azzopardi Muscat, the Director of the Health Services Department and Public Health. So we ask, it's going to be the first one to speak, we asked them to tell us about an organizational innovation that they want to point out. They have already been in part of the summer school and presented other innovations, but we asked them to focus on one of them and start telling us a bit what is that innovation, what is the challenge, and most importantly, we want to hear about the drivers for that innovation, as I said. So we were talking about the many ones that Euro is putting in place, and one, it seems you're saying, Natasha, would be on primary healthcare, on supporting member states on the implementation of primary healthcare. Primary healthcare may not be a new innovation, and yet, as we heard from our presenters yesterday, in many contexts is a real innovation to implement effective primary healthcare. So what is the innovation as such? Why is it so difficult when it's been around for such a long time, Natasha? And how the office, the regional office of WHO is supporting member states in the implementation of that innovation?
Thank you, Joseph. So I suppose trying to, as you say, really innovate in primary care is probably one of the oldest challenges around. But I think what happened was that the COVID pandemic and the changes that had to take place around the COVID pandemic, we heard also from the presentations from Veneto region earlier around, for example, the acceleration also of digitalization, provided a window of opportunity. So in 2021, we took to the regional committee a new framework for how we would like to see countries being supported to take primary healthcare forward. And basically, it has 4 tenets, but we didn't put them in the usual WHO order. We tried to go for a really practical approach. So we said, first and foremost, we need innovative infrastructure. The old tiny clinic, a room somewhere in a center, nobody wants to go there any longer because they know that that is not the place where they are going to get the care they need. So the first thing was to talk about really designing fit for purpose for the needs of the population in terms of the infrastructure. But the infrastructure alone, this is a side conversation that Isabel and I were having just before this session, is not going to be enough. It's necessary, but insufficient. So the second thing is about the health workforce. What is innovative about the primary healthcare workforce? What is innovative is that clearly it needs to be made up of a team of people, and a team of people that also includes people working very much in the area of psychosocial care, because primary healthcare needs to reach those who are at risk of being left behind, the older persons, the children and the families from disadvantaged areas. And therefore, you need a far broader range of expertise. So that is innovative. The third thing, primary care is multimodal, and it's here to stay. I wanted to come back almost to Mirko's presentation and say, I want to see those statistics in 2 years' time and to see whether we're actually going to find a balance with the use of telemedicine, or are we going to see this declining, or actually are we going to see this taking over? I think we're at a critical juncture, and it's up to us to get it right. And this is, I think, again, the third innovation. The third innovation is that primary healthcare has tended to be left behind in the big digitalization projects that have focused on hospitals. And what we need to do is we need to bring these together. And the fourth one, I leave it for the end, you're not going to be very happy, is the governance. But I leave it for the end because it's the hardest one for people to understand. So normally I say, okay, if you have the infrastructure, if you have the workforce, if you have the digital coming together, then we can start really talking about the incentives, the financing, the governance, and the politics. But you came back again to the question, why is it so difficult? Giuseppe, you have stepped into many hospitals, like I have, in many different parts of Europe. At the end of the day, a hospital is a hospital is a hospital, more or less, plus or minus a few tweaks here or there. Ask the big design companies that design hospitals everywhere. They have a prototype. They tweak it a little bit, and it's the hospital. In no primary healthcare system are any two primary healthcare systems alike, even from one region to another, urban, rural, because the primary healthcare system needs to be tailored to the population. And this is another innovation. We can't design for the people without the people. And over here, I think is where we really need to bring the communities to determine what they need and how to do it. Will we be successful? I can talk a little bit, but I don't know whether you want it now or later about the instruments.
I'd like to hear, that's perfect. We have the 4 pillars, the 4 components, which gone beyond Almaty, but the idea of Almaty is still there, that then went to Astana. How do you help member states to overcome the real reluctance to move from hospital-centric to primary care-centric? We've been talking about that forever. What is the key of your success? That how do you go there and support the minister to make changes? You go there benchmarking, you go there giving medals, you go there training people. What do you do so member states can implement that innovation? And therefore, what are the lessons to implement primary healthcare to be successful?
What did we hear during COVID, Joseph? We heard during COVID the Swiss cheese model. No single intervention on its own is enough. But if you layer the interventions one after the other, then you start getting some chance of success. So, of course, we produce the evidence, we produce the reports, it's our bread and butter. You help us to do that. We benchmark, we report on what is being done.
Does that help, benchmarking, naming and shaming?
Yes, it helps if it is taken by the media, if it is taken by the people, and it becomes a cry of the people. If primary healthcare is something that we are trying to impose on the people, no chance. If it becomes something that the people taste, they like, and they want more of it, then we are in business. But the reports on their own, they are of very little use, sadly.
Yeah, I'm very sorry. Yeah,
very
because
sorry,
that's the way we make money. But you know.
That's it. The second thing is to be there when the countries need you, when the minister is with his back against the wall, when there is the outrage from the stakeholders, when there are the financial difficulties. That is when you need to be there present by their side, helping them to answer the criticism in closed-door policy dialogues, if it comes from the Minister of Finance, in the open, basically even sitting down at a press conference. It's about empowering the Ministry for Health, so being ready even to go beyond the Ministry of Health, to the Minister of Finance, to the heads of state, to the prime ministers. And this is an opportunity that COVID gave us. It opened these doors at a high level, and we need to run through them very, very fast. We then
So it's the window of opportunity.
We then also,
Rapid response.
try not to come in as WHO and say, this is what you ought to do. Because WHO, at the end of the day, I mean, very few people perhaps know that I was in the hot seat as a chief medical officer in a country, because today I wear the WHO lens. But when we team countries together, that is when I think some of the real powerful learning experiences are taking place. And we are seeing this hunger almost to go and to see more than one setting, because you need to see what works for you. And then finally, another dose of opportunism. You need to understand what the country is ready to do and to enter through the window that they are ready to open, and not through the door that you want to enter because you are WHO primary health. Okay? So if the window that the country wants to open is digitalization, we find a way then to say, okay, digitalization is your project, but you need to involve both the hospitals and the primary healthcare. Let's start talking about integration, talk about pathways. If the window that they want to open is hospital care because of emergency services, we go, we sit with them and we say, okay, you want to talk about emergency services. What is your problem? Could the problem be that you have a weak primary healthcare system, and therefore this is where the investment needs to be? So I think it's really coming in with a lot of determination, but also a lot of humility, and being able to be there in the right way, at the right time, doing what is necessary, and doing it all, but starting with what people are willing to hear.
That's very helpful. Thank you. One of the key elements, Natasha, very briefly, is the profession, and we'll hear from our colleagues from Vesna and from Stefan and Lisa Maria later on, probably. I mean, the profession is not that keen sometimes into primary care. Some of the profession in primary care, they're really burnout. They're not. How do you support members on that? I mean,
so I think, again, the first thing is that actions need to work to match the rhetoric. So if we say that we want our health workers to work in primary care, we leave them alone, we leave them unsupported, we pay them less, we give them worse working conditions, we have nice new air-conditioned hospitals and very ill-equipped, sad primary healthcare facilities. What message are we giving? The message that we are giving is that if you are good and if you are the best, you manage to get into the hospital specialty. Those that are left behind are left to work in the facilities that are falling apart, unsupported. So you need to start slowly making this change. And we had one of the innovations that we did this year through our center in Almaty is the Let's Talk Primary Healthcare. It's like a radio show, like a talk show. We started with 1-2 episodes and we were surprised by the support and by the participation, and that people are, it's like a Netflix series, you know, you want to know when the next episode is going to be.
So making it attractive, for the profession and for the patient.
Because we try to make it attractive. And one of the sessions that was really reported on was when we were talking about something that perhaps very few people are willing to talk about, which is prestige. Why? Because people might say, but prestige, that's a luxury. No, if we are not ready to talk about prestige and to say that we want to make primary healthcare prestigious, one of the things that I remain very proud of today, just from my time as Chief Medical Officer in Malta, was that the positions in primary healthcare used to be the last ones to be filled. We set up a postgraduate medical education program. We worked with the unions to get the right conditions.
Has this
and
changed?
Over a period of 10 years now, people actually spend years in hospital trying to get training, qualifications, and experience to be able to have the profile that allows them to go and work in primary care.
I think we want to ask you more about that one, because that is really the key the key element. Thank you very much. Very clear. Natasha, I could ask you as well about the kinds of organizational innovations within WHO. Maybe we have time, we talk about that. But I want to move now to Isabel de la Mata, Principal Advisor on Public Health in DG Santé, working with Director-General and the Commissioner. Isabel, the Commission, and we heard already from Tavernakis, is doing a lot of work to support reform and innovation. Later on in the week, we'll have Sasha Kenko, who works in DG Reform, another part of the Commission that supports reform and innovation. We'll hear more about that, and hopefully we'll have opportunity to talk to Isabel, each one of you as well later on. But from you, what I wanted to ask you, because you started in the opening with a very, very useful presentation about that, is we've seen real reform in a matter of weeks, if not days sometimes. Particularly, we've seen the ECDC change, the EMA, the HERA, the wife of Zeus, being established in the Commission at the breakneck speed. We know why. We know it's, of course, the COVID and the threat. But there have been other factors there. And I'd like to hear first a tiny bit of the role of these agencies, very briefly. Most of you know about them, but I'd like a bit of a reminder, if that's okay. And then particularly I would like to hear, what were the other factors that allowed you? I mean, why some countries whose names I will forget now, always reluctant in terms of subsidiarity and so on, were so quickly accepting that it wasn't COVID alone. There must be other factors there. And the second question later on is going to be how we make that sustainable to continue with European Health Union changes. So lots of points there. But let's start telling us a tiny bit, for you, what were the main innovations that took place so quickly?
I think that it was COVID. It was COVID, but taken from a different point of view. So we have several instruments we have always had. We have the treaty, but we were always concentrating in the wrong article of the treaty. That is the 168, where everybody is focused on subsidiarity and not competence for the European Union, just competence for the member state. But the treaty, I mean, has a lot of articles, not just one. And the first one that was used during at the beginning of the pandemic, I mean, already from February, March 2020, was the 122. That says that that member states have to support each other in economical crisis, and when there is a problem in one of them, that the problem could be war, could be the economical crisis was there, and that allowed us, for example, to deploy the emergency support instrument that was used for health, mainly because the COVID was a health crisis, but from a different point of view. I mean, for the first time, were not only the ministries of health involved, was not purely a health crisis, was a global crisis. Everybody was involved. The council deployed the integrated political crisis response instrument. So was outside health, to say like that. So it was a global response, not focused, but global. to a problem that happened everywhere. And if you remember, even at the beginning, there were countries that were reluctant, that they wanted to close the borders, not only physically, I mean, but forbidding the export of things, wanted to go on their own for the vaccines. So I think that was one of the key issues that we were discussing globally with governments, not just with Ministry of Health. I mean, something that we have been saying forever, that we need to convince the ministers of economy how to invest in health, bring return, the ministries of social affairs, ministries of labor, for, I don't know, for musculoskeletal diseases, something like that. And we were not successful. But suddenly we had that was not anymore something imposed, but was a natural experiment. So for the first time, we were talking to everybody. I think that was one of the issues. So we began to buy vaccines, to buy masks, to support, and also other things that we were not allowed to do before. I mean, I remember 2015 when I tried to discuss to one of the services of the Commission that we wanted to use the health program to buy medicines. And I was like, no, it's forbidden. It's not in the remains of the health program. Now I was buying medicine, the remdesivir, I was buying tests, I was buying masks, everything, and there was no problem. So because I mean the issue was focused in a different. And then we realized that I mean not only that member states could not go on their own to solve this crisis because it was global, and that we were also learning from other countries how other countries were, I mean, third countries were dealing with that. And that is, for example, the example of the BARDA for the creation of the HERA, the change of the ECDC, the change of the EMA. So issues that we were discussing for years. Who will be in charge at the European Union level of the medical devices? Nobody, because there are multiple national institutions, I mean, notified bodies that were in charge of that. But then we modified the regulation of the EMA, and that passed in 1 year. In 1 year, we had a new regulation, and the EMA is now taking care of some of the aspects of medical devices. And another thing that seemed impossible before, that is the shortages. So once that you make the authorization of a medicine, authorization to put in the market, the EMA role was finalized. I mean, the Commission, they give the technical support. We say that it's okay to put in the market, and then it's finalized. Nobody was in charge of checking if this medicine was already in reality put in the market, if there were shortages, if the prices were different, it was put in the market just in Germany and not in Malta, or things like that. But in reality, everybody wanted that, and that was demonstrated that in 1 year we passed the legislation saying that. For the ECDC is a small agency, was a small agency. It was conceived as a network of networks, but we needed to change the level. So I used to say that for the EMA, we put to the block, we put an side block, but for the ECDC, what we did is from here was like that. So it was growing in the totality. So increasing the competencies, the people, the funding, and everything is nearly approved, but not yet. And the other piece in the European Health Union was the cross-border health threat. That is nearly finalized. I mean, it has to be just the last step of approval. And that we have passed, this is something very important. We had already a legislation on cross-border health threat, but was a decision. The decision is here in the legislative level, and now it's a regulation. So the top, from the bottom to the top, in 18 months. So there was an opportunity, as I said, because
a honeymoon of change.
A lot of things, and the pharma, and the HERA, that is not an agency, it's an authority, but it's a DG of the Commission, the same. And the issue is that they are so busy doing response that still they don't have the time to do the preparedness, but has the two legs, the preparedness and the response.
So there are two elements. One, you're saying that some of the instruments were there, and they were used. So some have been arguing that there's a need to change the treaty, and I know colleagues in the Commission, other places have been said there's no need to change the treaty because the instruments are there and we need the political will to use them. At the same time, many regulations were passed, new agencies, but I assume because many of those plans were already in the top drawer, as it were, ready to be implemented, and you have the window of opportunity of COVID. The question is, as we said in the first day, do we need COVID, a war, famine? We need one of the horsemen of the apocalypse to get change, or can we sustain some of that? Do you think that there is a change? Actually, I should ask here the member states more than you. And I'll ask you this question in a minute as well. Is there a real support now for member states to continue with this public good at European level and giving you more powers to apply not only to communicable diseases, but other common threats in Europe, European Union?
I have some doubts. And I know that this is being registered, so I'm going to...
Can you stop the online, please?
No.
No? Okay, sorry.
I mean, we have done the last Eurobarometer in April, May this year, and the European citizens support more involvement of the European Union in health. This is what the results of the Eurobarometer say. We had also the Conference of the Future of Europe, and also health was one of the legs of these discussions. And there was also a big support from the citizens to more involvement of the Union on health. At the same time, we passed from health programs that were around 500 million euros for 7 years to one that in the Easter 2020, when we received the proposal from the budget for a 9.3 billion, we have nearly a heart attack. So passing from 460 in one period of 7 years to 9.3 billion was, I mean, more than 20 times. Now is 5.3 billion. But what is happening? That we are discussing, we need to approve the program 2023. And what is doing the council? They want to cut 26% of the budget of the EU for health for next year. So COVID has going down, and it seems that now the interest is also going down. So we need to try to keep this interest. And this interest, as I said, is not. I mean, the ministries of health, they are fully involved in the EU for health, fully involved in all the proposals, but they are not the ones that discuss the MFF and the financial perspective. And it's not that they think that health is not anymore important, it's that there are other issues. Now we have Ukraine and and the gas and many other different competing points attracting the funding and the attention. And this is a problem that in health we are mainly until now, or we have been always reactive and not proactive. And we need to change that, but this is not only in our hands.
Okay.
And we try to involve all the stakeholders, and we already created, thanks to the COVID, different relations with the health professionals, with international organizations, and etc. But we need to, that we created with the others, with the ministries of economy, with the political representatives in Brussels and in the member states, that they are back saying, hey, we don't have COVID, but if we go back to the initial situation, we will have whatever the name in the next 5 or 10 years. So we need to keep that attention.
The threatening. I will ask you colleagues in the room and online to think about ways in which we can be more proactive, ways we can lead the agenda without having to have another pandemic or starvation or war. Let me move to Stefan Exwalder and actually the member states here. Maybe you want to react as well to the points of Isabel. Stefan Exwalder is the Director-General, is the Director of the Health Services Department in the Austrian Ministry of Health. I just gave you a promotion, not yet the Director-General, but in the way there. and actually someone with lots of experience working at European Union level and implementation. We'll hear from Stefan as well on a number of innovations that he's been involved. But there's one in particular that being in Veneto, we thought it would be interesting to hear today, which is the evolution, the decentralization or the evolution in Austria and the complexities in coordinating and setting priorities between the Federal Ministry of Health and the different landers. How do you address that? And you came up with some interesting innovation we want to hear about and some of the drivers and factors that allowed you to implement it.
Thank you, Joseph. It's wonderful to be here, and it's going to be tough for you and for me. I hope it's tougher for me than for you to follow me, because I will try to connect everything that I've heard so far, because it goes so well together. I prepared something and we discussed it of a new governance scheme, but I really would like to react first to a couple of points, because I think actually to get that debate going, it's almost more relevant and interesting. You asked for the crisis. Do we need the crisis? And to be honest, we started our last bigger healthcare reform after the financial crisis. So I'm afraid somehow we need the crisis eventually, just to see that we really need to act, because at least in some of the countries, we have a quite good situation. I think we still have a lot of money that we spend for our public health systems. Sometimes if we look at the outcomes, we don't achieve the best outcomes necessarily, considering the money that we spend. And then it's helpful to, and we should not need a crisis for that, obviously, but to get a step back and look at the system, do way more performance assessment and checking actually how can we make sure that we get better. Now, with also what was said today in the introduction, was that we definitely need to think about ways to coordinate more on all levels. There was, I just had the discussion, or found it interesting that we saw the example of the Veneto region about HTA and pharmaceuticals, about the centralization, and it was a centralization to the regional level. Obviously, well, partly because Austria is maybe double the size of the Veneto region, not even, but definitely we have an issue in collaborating better on the international, on the European, but also on the national level. And when trying to come back to the points that Isabel made, and in particular also Natasha made, I will use 1 or 2 minutes of your time to introduce that new governance concept that we developed, but then particularly jump into the primary healthcare reform that was the result of it, and it fits so nicely to what was said. So what we did in back 2012, the pressure was enormous. The budget, the public budgets were under pressure, and we will see that coming in the next years, unfortunately, most probably. And we knew that we have a lack of care coordination, and the fragmentation leads to inefficiencies. I mean, this is obvious and it's trivial, but the solution is not trivial. So we got the recommendations back then from the European institutions, from the OECD, from others, to reconsider the competences, streamline the constitutional competences. However, that was not a feasible way forward, because simply there was no constitutional majority to change that. So the discussion is going on for more than 50 years, I would say, to change the constitution and the shift in competences, but it's not a very efficient one. So we have to keep that. That's why I think it links nicely to what was Isabel said about Article 168 of the Treaty of the Functioning of the EU, because we have this discussion for so many years, and we know that we need to find other ways of working together. And the crisis again has shown there are ways. So what we did in Austria was introducing a governance scheme that follows a balanced scorecard approach. And it's a bit ridiculous in a way, but it is a second best solution approach. We knew the first best solution would be change the competences, get it right. But for countries with the split of competences and very decentralized countries, that's not easy. And it's a very tough topic. So we went for a second best solution approach, which meant that public governments signed a civil contract and left the area of state treaties, acting on the level of state treaties and of laws, obviously, but we didn't stop there because we were blocking each other. So we started with civil treaties that we were all able to sign and introducing a very strong system that relies on accountability, defining all objectives jointly, which takes way more time, is very inefficient in the way of getting there. But once you have identified them, particularly those areas where you are either in different sectors with different competences, or you deal with questions that are of super, not on the level of the regions, but on a national level relevant, it's much easier once you have identified those. So it takes a long breath, and it's difficult. It was an interesting exercise, but we have now being able to develop joint views on many of those topics, signing them in a contract for the first time, establishing a nationwide monitoring regime that is obviously public, that gives the exact measure on or indicators on a variety of measures. And it also shows which regions, where are people getting the care as we jointly defined that we want people to get care. And now for the bridge in primary healthcare, also what Natasha was saying with the 4 pillars, that was the first case where we needed this new system, because we know one of the positive aspects of a strong primary healthcare system is that you reduce hospital admissions, and the quality of care is better. But the problem is, and we heard it a couple of times, what is with the financing? Primary healthcare is within the responsibility of the social health insurance, the hospitals of the regions. So if there is no financial countermeasure, the incentives are skewed. And for those questions, we didn't get through all of them, obviously. We wanted to have many more measures where we have these linkages being implemented, but at least around 65% of all the measures that we introduced in these contracts, we were able to implement them. And then, and maybe that's also for later, we were able to go into exactly what has been said, have more money for the system. We had a problem within the country because we spent so much money already that there was no acceptance of having more money. And we know for investment, you need more money. It pays off in the long term. But if you start arguing with the long term with the Ministry of Finance, it's a bit tricky sometimes, right? Because there are immense pressures. So what we did was jointly with the European Commission, setting up, using the instruments that were available, starting with the processes, with the health workforce, making it more attractive. And now finally we're able to have a huge and the biggest project within the Recovery and Resilience Facility to support the establishment of primary healthcare units in Austria, to bring in the dynamics, so to make the innovative infrastructure that we all want to see. But then also use 10%, so 10 million, to make it more attractive, to use it for health workforce, not for paying, obviously, the health workforce, but to making capacity building, to be able to show, particularly to the young generation, how working in the primary healthcare sector looks like, because they know the hospitals, but they don't know the.
That nicely aligns, because you talked about we talked about 2 innovations. We talked about the last one was on primary healthcare, aligning very much with the lessons there, making it attractive, the infrastructure, investing on the training and the new profession. And then you're talking about the governance, which is always, when we're talking about organizational innovation, the governance innovation is the most complex and complicated, really, both in this case. Let's go back to the governance, because I think it's very relevant for countries in the south and in the north, actually, that are highly decentralized. So you decided to bypass the constitutional complexities and you went into this civil contract, but there was not much money there. You're telling me that it was like 0.5% of the whole budget. And yet there was an incentive for these landers to work together to sign the civil contract. It was, again, naming and shaming. It was political pressure. It was the transparency we're talking about, where you were comparing between them. what was the elements, were the drivers that they got to accept this civil contract? Ownership, perhaps? Because you involve them, you set a very complex process of setting priorities together?
Yeah, absolutely. Now I need to be careful again. It was obviously not a bypassing of the constitution, but a creative way of interpreting the constitution. Let's put it
delete
this way,
that,
right?
ignore that,
So,
ignore that.
But yes, we have those difficulties, and we need to deal with those challenges based on the split of competence. I mean, now we founded a company, a limited company, all the public institutions to make the healthcare planning, because neither the federal state can plan the infrastructure on the regional level, nor can the regional level for the social health insurance. So if you talk about integration of healthcare planning, that makes it extremely difficult. So we had to build to establish a company in the end, all
to do
public
healthcare planning.
authorities to do that. But it's now within the constitutional court, so we will see if it survives. But
isn't that the job of the Ministry of Health to do planning? Why would you have an agency?
No, we do that, but to force the planning on the regional level, this is only a competence of the regional level.
Take note of that.
And to make an integration of that, we now have a company that does the planning for everyone, and the owner of this company are the federal state and the regions. I know it's
key. Yeah. It's ownership. It's a process in which they're involved in setting.
Ridiculous. And for this new way of working together, I think you can only do that if you make sure that you have the necessary platforms and the trust to even go into those creative ideas. Yeah. Because if any of the regions is not sharing the ownership, then you cannot do it. It's something where you have to have everyone on board. And what we did was obviously not only fresh money, because there was almost no fresh money, but it's a matter of timing again. So we introduced that new governance system that we call Zielsteuerung when the financial equalization negotiations took place, where all the money is negotiated, adding a bit of extra money, but then in particular saying, but we need more information, and nobody
money for information.
It's clear that for the transparency, it helped us so much for all discussions.
Well, we're discussing with Dr. Flora. I would like some reflections later on at the end about that. It's interesting, this top-slice money, even if they're small amounts, have a very powerful incentive to work together. Let me move to Vesna Petriks here. Vesna, you wanted to talk, we talked many reforms also that you personally led in your country. One of them that's closest to your heart is also primary healthcare and the role of public health into primary healthcare. I mean, again, something since Almaty times, we've been talking about primary healthcare being also public health. So this old innovation, and yet one that many few countries have managed to implement, how did you address that?
Well, let me first to refer also to my colleagues here, because Steph and I also carefully listened to what was said, and also to maybe respond to your question on proactivity. Yes, there are many countries, I think, especially not maybe in EU, but in other parts of Europe, where they struggle with establishing primary healthcare. But Slovenia was one of the fortunate countries. We have 100 years of a very successful and strong primary healthcare, as well as public health. And they worked better or less good together through all these 100 years. So with this potential, we should feel safe. But that, of course, is not the case, because the challenges approaching us in health sector, are the same for all countries, and we have to adapt, and we have to change our systems and be very innovative in doing so. And referring to proactivity, it's easy to say, let's be proactive, but there are only few opportunities where you can be constructively proactive, really. And one of opportunities for the country is definitely when you are having a presidency to EU, for example, because this is a moment where your country is in charge, and you can get easily other countries on your side if you have something good to share. And also the Commission is there, trying to work with you. And I have to say that Slovenia used this opportunity during our presidency in 2021 really well. And we went for exactly what we are discussing here. We went for, how we could better together
invest and work together, even not just invest in innovation. Several countries working together to innovate, because the challenges basically are the same. And as it was said, the systems might be different, but while the challenges are the same and there's no system that is perfect, we might find some solutions and then, implement it a little bit differently. Yes, of course. But still, working together is always better than trying to figure it out on your own.
So music warriors, Reinhard, those of us who work in comparisons and learning from each other. So it helps to implement innovation when you work with other member states with similar challenges.
Even to develop innovation, because I don't know why we constantly speak of only implementing. For example, if we are speaking of organizational innovation, I think yesterday, you will all remember, we were discussing, that we are developing innovation in pharmaceutical field. We need some 10 to 20 years. Somebody said we need 20 years, when you have organizational innovation, you spend sometimes, it can be really fast, good idea, but then to implement it and to adjust it to the circumstances and the context, it's really difficult and it can take a long time. And here I'm speaking of a kind of innovation that was implemented in Slovenia in primary healthcare. We were aiming, because the evidence showed and everybody, WHO, everybody was saying, prevention really matters and you should integrate preventive services with public health services, and you should also better work at community level, health, social affairs, schools, NGOs, wherever you integrate all the services there. So we were after this integration and we were very clear about the goals. We wanted to reach the most vulnerable as well, not just the ones, that usually come to the health centers, but to reach to the most vulnerable. We were aware that we have to reach out from the health centers. How can we do this? We have to change our system. That was, of course, we had community nurses, but that was not good enough. It didn't work like that. Community nurses have their own assignments and that was okay. We need something different. And very early in 2003, I think we have developed health educational centers, but soon we realized that health educational centers that actually had appropriate skill mix, not maybe yet appropriate, and they were within health centers, not appropriate part of the population was attracted to those centers. It was mostly, retired women, people with a lot of time that wanted to reduce weight or go to the cessation. So, we didn't really were successful to attract those people that were most in need, people very obese, people that with all sorts of problems. That was not the fact. So then what is important and what actually happened, we think, that innovation, it's very well accepted that technological innovation needs money and big investment. A lot of money needs to be invested in organizational innovation, in trying to implement in particular. This is something that should be done just like that, transforming something. And so it's not really realized that there also investments are needed for trainings, for organizing it, for evaluating it, monitoring it constantly, and for the governance. Somebody needs to do all these functions, And we had this kind of opportunity when the funding through cohesion funding was available at the EU level. So we said, now is the time, and we went for it. And actually, before that, we also used Norwegian funding. So to make this story a little bit shorter, it was a bit more complicated because Norwegian funding was used to develop a kind of a model, but in 3 healthcare centers, but then with much, sorry?
You were creative. How to use the money.
Yeah, we were creative, but then, the cohesion funds were much bigger, and we could pilot the model in 25 centers. They had to apply to being pilots, but that is about the ownership. And we were saying before, ownership is very important. Whatever you do, it cannot be imposed on people working there. You have to make sure that, they feel they own the project. this was done quite well, maybe not as well, but it's always like that. So we developed these centers, and their new role was to go out of the healthcare centers. These were called now health promotion centers. The previous were health educational center. We changed the name. Now a new concept, health promotion centers. Their role was, and their goal was, to reach in the community to the most vulnerable. And for this to happen, they, at the community level, they have to work together with the community administration, with social services, with NGOs. And this was really innovative. In particular, that was so because people in healthcare were not used to do so. So who was there to support them in doing so? Public Health Institute, with all these regional parts. We have one public health institute, but in all regions we have entities, and they work with local communities and health centers to support them in changing their ways of working. And I think this was something that was also very innovative. And maybe what is also important to say that this project was going, was developing at the same time with another innovative approach where we introduce, as we call it, reference registered nurse into the system at the individual level, helping patients with their chronic disease and with the preventive services and navigating patients through the system when
Excellent.
it was needed. So this person, half nurse for one physician, family physician, was introduced in the system almost at the same time or a little bit before. And this was actually completing the whole innovative approach and
Excellent.
the change in primary health
And
care.
is it been sustained, this? You think that is beyond the pilot?
Yes, if you ask me, this has been, especially the reference nurse is now in the system. It's financed through insurance fund, so it is there, and all the ambulatory, even the concessionaires, they have their reference nurse, all the doctors or family physicians, they have it.
Excellent.
So that is implemented and that is now sustainable. It will need to be upgraded. A lot of training will be needed in the future and evaluation. It's not working everywhere in the same way. Some medical doctors, they do not really understand the role, as I explained it, prevention, navigation and so on. But this is a matter of, further investments, but it is there, it's systemized.
The culture's changed.
The other part, the 25 centers, we are now looking for additional resources. Most probably we will again look at the
Isabel,
European
you must be pleased
funding
today.
and mechanisms because, without investments, there's nothing. But we have 63 healthcare centers. So all 63 is a matter of equity, needs such centers, and
Perfect.
we are on the way of doing it.
Thank you. So all the ingredients there, clearly the evidence of double job, clearly the cohesion funds and the support of the Commission, the ownership is very important, the pilots very important, the introduction of this new figure to support that very important. So you seem that to be change the culture and spreading. Very, very nice. Thank you very much. Last but not least, by any stretch of the imagination, you're usually first, Lisa Maria, because you're very senior as well. Lisa Maria Volpio-Pulkki is Director-General from Finland, Chief Medical Officer, and actually the chair of the European Observatory, and Vesna and Stefan are the co-chairs of the European Observatory. And thank you, Lisa Maria, because you broke your holidays to be here with us a couple of days, which we're very, very grateful. It really, if one challenge is to integrate public health into primary care, the other usual suspect challenge is social care and healthcare. This is one of the ones that is pursued everywhere. The Veneto is a region that's done a lot of work in that area, but is one of the usual suspects, one of those challenges that every country has to put in place. I'm never sure. I always put Finland as the example, Lisa Maria. Then I talk to you and you say, well, no, but it hasn't worked that well. So tell me, has it worked? And if it hasn't, why? Why were the drivers? And if it has not, why?
Okay, thank you so much. Just a great pleasure and honor to be here today. I used to be the Director-General for Strategic Affairs until last October. Now I'm Senior Advisor to the Ministers and the Permanent Secretary and so on. But in any case, I would like to reflect a little bit on the issue of proactivity also, and go back to what Vesna already said about the window of opportunity that the EU Council presidency offers a member state. So Finland introduced the concept of health in all policies during our presidency some time ago, and then sort of updated it as the concept of economy of well-being in the second half of 2019. That's not a brand new concept, but in any case, then came the COVID crisis, and at least for us who work in the social and healthcare, it was a note added in proof that if we handle the epidemic properly, that's also good for national economics. We know that many economists still feel a little bit uncomfortable with that concept because it doesn't fit their theory of macroeconomic incentives. But I think that by bringing these concepts to the political language and political arena, gradually we are going to get the message through. And at least Finland is going to work on that issue in the next few years. And it's politically accepted in the country. So you asked me to describe a systemic innovation. Well, we talk about innovations, but politicians talk about reforms. It's the same thing.
Terminology.
And the big reform that the Commission, for example, has been asked us to do in the semester recommendations for many, many years is now finally becoming true, that we are going to integrate all health and social care under the same governance and the same budget. And at the same time, going from about 200 separate organizers in a small country with 5.5 million inhabitants to roughly 40 regions. So we are going from a very decentralized model to a regional model. And at the same time, the financing model will be changed so that most of the money comes from the state budget on a needs basis formula to the regions. And that means that the health and social care budget is going to be about half of the national Finnish budget starting January the 1st next year. So health is always going to be there. It's a power play issue. But primary care and social care. So the Finnish system was and will be a universal public tax-funded and on the primary or basic level, actually largely free, very little co-payments, service for the whole population. For many years, almost 20 years, there has been an intentional and dramatic reduction of hospital beds and institutional care. That means that the pressure has been put on the primary or basic level services. And you could ask whether the resources followed the tasks, not necessarily, at least as much as should have happened. So we have been speaking about integrating health and social care on the primary level for a long time. And there have been even legal sort of obligations to the healthcare organizers, so these decentralized organizers, to improve the cooperation between health and social care workers inside what we call the primary care centers. They have employed, on top of doctors and nurses, social workers, psychologists, physiotherapists, and so on. But still, there has been this feeling that the care processes are not actually integrated on the personal individual level, and the experience of our customers and our patients has been the experience of fragmentation.
In spite of having them under the same roof,
us understanding,
coordinated.
Yes, exactly. Then came a very dramatic study from a city of Oulu. We have known for a long time that it's about 10% of our patients, customers, clients, you name it, who give rise to roughly 80, 85, even 90% of the cost. But in the city of Oulu, in the north of Finland, which has a university hospital, they were able to show that about, actually, who are these people, this 10%? 1/3 of them actually are customers or patients of highly specialized care, very expensive care. 2/3 of them are actually people who consume a whole lot of both primary health and social services. Now, who are they? They are families with children with health or mental problems, vulnerable families, vulnerable group families, elderly people living at home because we don't have any institutional care anymore in practice, people with drug and alcohol abuse, chronically disabled people, and mental health patients. And that transparency brought forward the urgency of really bringing together these services. And by social services, we mean services provided for elderly people, disabled people, mental disease people, mental patients to be able to live at home as long as possible. Child welfare services for families who need extra support, special services for substance abuse, which is a very sensitive issue, whether it's a question about a medical problem or a social problem.
Yes.
And then emergency housing, emergency support for anybody who is in need. And you know, people who need these services practically always have a health problem also.
But Lisa Maria, this is really, really, really helpful. You made a very powerful case, but does it work then why doesn't it work? Are you seeing savings in this 10% that they spend 80%, as you said in the study? Are you seeing services efficiencies and improvements by having those working with each other? Because it should be the case. You have all the ingredients. What puzzles me is you have all the ingredients. You have the global budget, you have the professionals, you have the health center, you have all of them working together. Why doesn't it work? And what should you do to make it work?
Yeah, it's a question about the evidence again. We have had pilot regions in the country which actually brought together these services much better than the other regions or cities or municipalities, but there are obstacles that remain. And at the same time, when we do this organizational reform, that we bring all these services under the same management and budget, we have to tackle the other obstacles also. Because from these pilots, we have some results that show, let's put it this way, some process indicators about things being more efficiently handled and the professionals being more accustomed to working together, and also some patient satisfactory indicators, but not that extensively. Actually, the evidence that supports comes from the health and social care managers in medium-sized municipalities and big cities, because it's the qualitative evidence that say there's no way that we can continue the way that we do. And if they speak together to the politicians, then it creates the feeling of urgency in this issue. But the obstacles that we have left, there's different legislation for health and social care services, and the legal position of a patient and a social care client is entirely different. Because for social care, you have very precise legislation who is entitled to what kind of services, so they are subjective rights. And so the social care professionals put into practice the legislation. But on the healthcare side, you always have the so-called clinical judgment. And how do you bring these two entirely separate legal concepts together is one thing that the focus is on the records, because health and social care records have been separate. Now they are being brought together, and probably based on the patient's consent, the specialists or the professionals are able to see each other's records, which was a no-go for a long time. So that's one of the key issues. I
two
think
ingredients, legislation and common health records,
okay.
and social records.
Yeah, that's right. And then there are also professional doubts that the professions are stepping on each other's toes, sensitivities, and particularly, if I may say, on the social care side, because there is this feeling that health is such a strong actor. And it has been in the focus of the political discussion for such a long time. You can guess what are the reasons for that. When politicians and us as civil servants, when we talk to people, we tend to address health issues. And we are not that well equipped to address the social issues. Or sometimes we talk about just those over there. And it could be anybody of us. And during our life course, we are always also customers of the social care services. So understanding this brings us back to the
that
idea
culture
of
of health
universal
and social
system. So okay.
Thank you.
If I may say one more thing,
please.
Since we are now doing this, there is definitely not a real role model anywhere. If you know of a role model on a country or regional level about this huge merge of health and social from the very primary level to up to the university institutional level, please let me know. But I think that we have the obligation to document it. We have the obligation to evaluate it step by step all the time. And we understand that the legislation is not perfect. This was the first legislation that passed the parliament. There have been failed attempts previously. This is consistent with our constitution, but it's not perfect. And we have to be ready to make corrections over the years, but to be able to correct where we are going, we have to have evidence. We need to document what has been done. And THL, our National Institute for Health and Welfare, has done a wonderful job in developing the framework.
Excellent. You need continuous monitoring to be able to steer, because we are working in a very uncertainty area. As it happens, one conclusion is I'm a lousy chair and I'm running late, but I think you'll agree with me that this is innovation, this is implementation, this is real. This is not academics, although they all could be great academics, and there's a Prosecco outside. One thing you'll know between Reinhard and I, every year we have the same problem in Franchetti. I keep talking and he wants to go to Prosecco. But what we're going to do, as we started 10 minutes late, we're going to do the following, only 10 minutes, okay? And then we have Flor and Busse summarizing. What I like from you here, really, as I haven't been disciplined, you'll be disciplined to pay for my lack of discipline. And you want to contribute something of 30 seconds. I'll let you do that. And I'll get a summary perhaps from you, Dimi, or from Nicole, from the web, what's happening. So I want a summary from the web, the questions from the web quickly, then any questions here, and then I'll give you 1 minute each to answer, and one single driver. So you have to vote for one driver of all the drivers you heard that you think is the most important for implementing innovation. I know it's very difficult, but we don't have time for more. So I'll give you 1 minute each, including Professor Tavernaraki. Sorry that we got you here. I hope you enjoyed the session, Nectarios. So I'll ask you the same, 1 minute at the end to conclude with your most important lesson. And if there are any questions for you, again, address it very, very quickly, please. So Nicole, do we have anything, or Dimi from the web? Oh, yes, of course. You need microphone. I hate to share a microphone, you know?
I know, but I'm glad you're sharing it with me. We didn't have a lot of active participants in the second tile on the second part on the web. So we were having a slight online discussion among ourselves in the back. And we have two main points. One is the issue of public-private partnerships. And this extends from what we heard in the beginning from Professor Tavernaraki to the end, implementing innovation in primary care, for example. So how do we engage with the private sector in the best possible way to achieve our goals? And the other one is the room to fail. So how do we shape our ability to learn from failure and the room to allow ourselves to try things that might not work exactly as we want them to work, and to adapt them so that they do work in the end as we want them.
I think if I may allocate them, I don't want you all answer the same questions. I'll get Nectarios, if you could take the public-private, but at the end, because there's a lot of debate about the public-private partnership in innovation, a lot of heated debate on the subject. And then maybe on the failure, you want to try, as you were talking about failure, Lisa Maria, how you learned from that failure as well, although I don't think particularly the Finnish reforms are failed reforms. I think it's the opposite. But anyway, maybe I want to take that one. Any more questions from the floor? Quick ones, please. Please.
I'll speak very fast. Do you think we need to pay more attention to the language we use when we say primary health care? if we really want to move to a biopsychosocial model, and perhaps we need to think about preventative community, etc. And if I may, can we do anything about the false dichotomy between health and wealth when we want to try and address this tendency to show solidarity only during crisis, to make that more mainstream?
I'll allocate the first one to you, Vesna, because you've been talking a lot about that. And maybe, Natasha, the health and wealth element. Actually, we heard from Chris that the Venice office of WHO is very much looking at that element as well. But all of you could answer all these questions, of course. More points. I cannot believe it. Is it the Prosecco? Do I need to offer a bottle again to get another question here? Okay. I got the message loud and clear. Okay, everyone votes for you, my friend. So can I have oh, I'm sorry, I didn't see you. Apologies.
So very good discussion, and very important to focus on community healthcare or primary healthcare. The question is, can we achieve a more sustainable healthcare system without integrating the two, hospital and community sector? It's very exciting what goes on in Finland. But in many countries, these two systems are split apart, including in Norway. So can we push it further? Do we need to integrate vertically?
I'll ask then, of course, Finland, but also Austria, because I know you've been fighting a lot, and maybe want to say something, Vesna. And Isabel, I'll ask you to mention as well the public-private collaboration. You had a lot of debate during the vaccines, the buying of the vaccines and other pharmaceuticals. So quickly, 1 minute each, responding to the question that has been assigned to you, dictatorially speaking, and then one reflection about one driver to take home.
Health and wealth in 1 minute. That is a big one. But just to say that we are working on this. We're not calling it health and wealth. We're trying to find the window of opportunity. Countries are looking to rebuild societies because they are afraid that societies are becoming fractured. They are moving further apart. And so in keeping with what Lisa Maria said, we can't afford a sizable chunk of the population to be left behind. And that is why we need to build different economies. And we are working with the Observatory, with other partners, to try to make the argument that investing in health is good for this new type of economy, but building a new type of economy, which some people are calling, the economy of well-being, an economy that puts people really at the heart, where you look at social cohesion together with GDP, not just the GDP on its own. And then we build this virtuous cycle. The driver, I think I said it, Joseph, do not try to impose things on professionals and people, but make them be the ones who are clamoring for the change to happen. So as long as hospitals do not see the need for primary care to be strengthened, it just won't happen. When hospitals start to falter, to fail, to be under pressure, and they realize that the fault of this is not having really the structures around them to help them cope, that is when the conversation starts to turn. Thank you.
Excellent. And I think your other one about taking the priority of the country as an entry point to reach your innovation, I think is a very clever one as well. But I wanted to say something. Isabel.
I don't understand why it's so difficult, the public-private collaboration in the area of health. In education is something that everybody assumes and is very easy, or in other areas. So here we have been fighting for years, and I think that we need already to understand that different actors can have different objectives, aims, intention, but at the end we need to all to work together, because private companies, for example, they are doing medicines. If they don't have who is going to buy that, and where they are going to be used, they don't make any profit. The public institutions cannot live without what the industry is providing. So differentiate these public providers, private providers that in some countries still are completely separated. make no sense anymore. In my view, we need to establish how the collaboration is going to be, but we need to integrate everybody.
But the how is complex.
I mean, we need to approach that, and we cannot spend another 50 years saying that is complex, that is complicated, and because of that, we are not going to try. We are not going to do anything. I mean, if we have solved in other areas, if we have solved on education, I mean, why not in health? And regarding the I mean, in one word, I support what Natasha says, is involving and convincing. In other ways, it's impossible to do.
Involving and convincing. Excellent. Stefan.
Thank you. Maybe also very quickly on the private public, I think also sometimes we are much further than we think we are in many of our systems, where a huge part is privately organized, but then with contracts and in a very public way regulated. So I think we can look at where it works well and go on. So for the integration of hospital care and or inpatient care and outpatient care and in primary healthcare, definitely we need to. I was talking about the financing problem because that screws the incentives, and the same is true for many other aspects. I should not do that, but I will do it anyway. We had the situation that we have a tradition of single-handed GP practices, and in the outpatient sector, typically single-handed practices. No multi-professional team, no other nurses, no other health professionals in the outpatient care. It led to the situation, and that were only rare circumstances, but we had people in hospitals because they needed a social worker. This is ridiculous. Yeah. So definitely we need this exchange. We need to strengthen the outpatient care, but by doing so, we need to make sure that hospitals and primary healthcare communicate. I don't know how much I think there is a possibility of integrating them. Yeah. And we need to be pragmatic. I think we should not have a very formal discussion that may be suitable in Finland and in some countries because it fits to the system or to the actual reform agenda. But definitely we need to find ways how they communicate and integrate better. Yeah, formally or informally.
So the digital is very important, as Dr. Flo was telling us.
Exactly.
And your driver?
The driver is obviously it's true. Being then the one also in advocacy with the partners. Sometimes I have a lot of impressions from the primary healthcare reform where we know and we hear how important it is. And still, I hear most of the GPs, because they have a very decent life, telling me, why should I change? It's comfortable. So if I take it too serious, it's difficult to get changed. So I will say something a bit different. But first of all, it's a timing. Yeah. And it's timing. And the second part is it's more than money, but it's also more money in a way. Not in the sum, but in redistributing money to make sure
the right places.
But it's about the advocacy, I would say, to bring them on board, or at least to do it jointly, obviously. But in a comfortable situation, why should you change? So I think we should acknowledge that too. That
perfect. Thank you, Vesna.
Yeah, let me first say something on integration of services.
But short, because Reinhard is looking at me very badly.
Sorry, I was short before. I'll be short now. So this hand of me needs preventive services. Do you agree? And this hand needs curative services. And my leg maybe needs social services. You don't agree because it's never happening like this. It's me, I need all these services and they have to focus on me. So that is why we need integration of all these services, because it's me who needs all these services. I'm the patient, I'm the, somebody who is in desperate need of the services. That is why integration. So there's no question about that. And maybe it goes even further. Let me mention this also. Sometimes even a family needs integrative services. For example, when we speak of obesity, because it's not just the child that is obese, you need to integrate all the services around the whole family. So integration, it's a must, it's no question there for me. When you would want me to answer about about what is most important in implementing innovation, I would say that when you're speaking of organizational innovation, which is very complex, you have many stakeholders there. The most important for me would be governance, to assure that there is a right governance at all levels and that everybody knows what their role is. The ministry knows that they have to provide resources, make legislation right. The public health knows what the role is at the community level and at the national level, the primary health care centers. And so everybody has to know the role, and that makes appropriate governance.
Perfect. Thank you, Lisa Maria.
Thank you. I will jump directly to the incentive question. So I listed 3 and I will pick one. First, added value, either proved or anticipated of the innovation. As a young emergency room physician, I didn't need any special implementation program for thrombolysis for acute myocardial infarction. It was so clear that it had added value. Second, political will, particularly in the case of systemic or reforms, so to say. And third, capacity to invest in implementation. That's why our decentralized system failed, because most of the actors didn't have the necessary capacity to invest in implementation. And of these 3, for systemic level innovations or reforms, I would pick political will.
Thank you very much. Very, very clear. Nectarios, we'll give you the last word. You had the first word, that will give you the last word for any reflection you want to close today.
Thank you, Joseph. So with regard to the integration and the enhancement of collaboration between public and private sector, indeed, I think this is something that we need to foster. We need to increase in the future. The crisis, the COVID pandemic, has been a catalyst of developments that we've seen in this direction in recent years, but it's not going to be the only one, and perhaps not the most difficult to deal with. We are talking about the COVID pandemic, but there are other challenges, health challenges coming up. For example, the World Health Organization is estimating that neurodegenerative diseases, Alzheimer's disease more specifically, are going to loom in the years to come. More than 120 million people are estimated to be affected in the coming decades. This is becoming a huge challenge, and we don't have a vaccine there to deal with, and there is no effective cure, essentially, for many of these pathologies that are going to be the next big challenge. So we do need this collaboration. We need to work together towards addressing these challenges. And the crisis has been a catalyst, but we need to move on and really keep up with what's coming up. Now, with regard to the driver, I think we are talking about implementing innovation here today, but we need to have innovation to implement in the first case. So we need to really invest in the value chain that results in innovation. So we need to really invest in research. We need to invest in converting, translating these research results that we have into knowledge, into innovative products. This is what we saw happening with the pandemic, when research that was being conducted decades ago actually was used to develop very, very quickly in real time effective vaccines and drugs. If we didn't invest in research, we wouldn't have such effective treatments right now. So to implement innovation, we need to first have innovation, and that's why we really need to invest in this value chain. We need to keep supporting the creation of innovation through research, because we live in a knowledge-based society, and innovation, especially with regard to healthcare, always comes from research, from high-level research.
Thank you very much, because you actually closed the circle of the summer school, because we've been talking about the value chain, the development and the implementation, and you go back to the beginning. Thank you very much indeed. You can bring your hands together to thank our great panelists. And with my deepest apologies to both of you.
Yes, I'm brief. I think we have seen a great session, both with the Veneto presentations and also now with the panel. And clearly it is a challenge. I mean, I think we heard what we in the summer school say, that what he said, said it is a knowledge. We said is this discovery, it's invention. So we need research, but we also, I think, saw in the panel discussion that many of the innovations which we could use in our health systems, they are on the shelves. Primary healthcare has been there all along. So yes, we need research, but we also need to be more critical and really see what kind of solutions, what technologies in the broader sense of health technology assessment are on the shelf. I think we have also seen that was some of the initial discussion whether crises help. We just heard crises probably help in implementation, less so than in innovations themselves, but it helps that we are more flexible to look for innovations which are often not so new and are on the shelves, that we are more willing to try them and whether they work. And then we have implemented innovations which maybe we call these reforms. If they are then regarding health systems, the reform is the implemented in innovation. But I think it became very clear that we have to be both looking for what is already there. And Vesna was, I think, stressing the point that we don't put enough emphasis on these organizational innovations, and maybe also the EU was not so well advised in designing these three pillars, that they are also getting a bit lost. I mean, that like an inventory of organizational reforms would also be useful. And I think it's for people like us here in the room to also be stewards of the system in that direction. But these were just short reflections, and now I'm passing on.
Thank you. Well, grazie a tutti.
Thank you very much. You always learn. You definitely always learn. And one should never miss the opportunity to learn. And I think that today's session, I will remember it for a long time, and I'll try and understand it fully. And I'm saying I will try to understand because I've got a personal habit of first asking, what's the use of something? And who is this useful for? So what and who? Because healthcare services are for people. And therefore, one has to organize something to answer people's needs. And I think that the big investment for us and our big innovation is with people and through people. Walls, drugs, buildings, infrastructure, sophisticated technologies. They do not speak, they do not talk. People do. They have needs and have been working for years about the aging of population. Have we adjusted our system to an aging population? Have we? Or are we still treating people in the old way as we did 30 or 40 years ago, when old people were 65? Now 65-year-old people are young people. So we have to think of our own organization and how it is being structured. And in doing so, we have to think of citizens. We have to think of what they are demanding, what they see, and what they judge also, and take stock of this. We need to take stock of this because things can be said and things can be done. The Veneto region this year in 2022 will carry out a survey involving all local health units and citizens on communities, on home care patients, hospital patients, and on healthcare workers, physicians, nurses, to understand their perceptions, how they view our system in terms of relational organization, access. Was it difficult to have this visit? Did you get your service within that time frame? And we would like also to break down data based on different areas of the Veneto region, because we don't want to, well, probably in Veneto there are no inequalities, but there are differences, and we don't want differences from this point of view, because we have only first-class citizens, and citizens have rights. We have goals, but citizens have rights. And when we say that citizens must have this or that, do we do it? And this step forward we are making today we are making with this survey is to understand how people perceive a system. And there are patients associations, and they will be involved as well in asking them what they want from us. Of course, we will then see whether this is, as it were, right or wrong, but we need first to know, because whoever provides a service must take into consideration the expectations of the service users. I'm not worried in terms of sophisticated technological innovation, because that's obvious. That's a given. I mean, we can't escape it. In the contemporary world, this sophisticated innovation cannot be ruled out. Even those who thought that would never buy a mobile phone 20 or 30 years ago, now they can't live without a cell phone. So we will never do without telemedicine in the future, of course. And in all our regional projects, telemedicine will be involved. Because this is unescapable. As a Veneto, as a region, as I said, or somebody said, we have 5 million inhabitants, and our vision is a system vision for the whole of the area, for the whole of the population. And when we pass measures, these are for the whole of the region. Of course, in the region, there are first level centers, second level centers, and third level centers. We need to think of better integration and continuity. So we have to think of a seamless system with, and through digitalization, we should better integrate the community level with the hospital level, which in the past were separated. Now we have systems which, let's say, require different organization. Urban areas require a different organization from mountain areas, and then there is the countryside. So we need to know, and then we need to think of an answer. We are not starting from scratch. Our system is, I think, well developed. In some cases, it's a sophisticated system, but we know that there are people who are doing better than we are in some areas, at least, and we want to learn and to learn from them and to do our best, because I believe that in terms of health, nobody is going to accept something less. We all want the top, and we must give the top to our citizens. This is the ambitious goal of the Veneto healthcare service. But when I was little, I was told that it is better to be ambitious than being presumptuous. I wish you a very good summer school. Thank you.
It's over. You're now really relieved. Please go outside. Look on the Canale Grande. There should also be something to drink.